Okay, welcome back. So now we'll begin on part two, where we, in part one, talked about what we might call the more analytical part of decision making in emergency medicine, which is a core principle because of the because we want to find the time critical conditions in the haystack that is all the patients in the emergency department. We want to find that needle in there, and we can we can do that through that method oftentimes, or at least that's the theory behind it. In practice, gathering the information and so on, as we also talked about, is a skill and something that we need to learn as emergency physicians and as physicians in general. Now we'll move on to dyspnea, and I will talk with you about another kind of theory, moving more towards the critically ill patient, and talking about it through the framework of dyspnea. It's not that the dyspneic patient is more likely to be critically ill than the chest pain patient. I don't know any data that says so anyway, but it is something that we often see in the critical care area. Where we need to take care of a dyspneic patient, and I thought that was the best framework for talking about emergencies and like urgently or critically ill patients and how we approach those. So dyspnea. Okay, so to talk about the theory behind taking care of the critically ill patients, there's lots of concepts that I could go into, and I think for non-emergency physicians, as this lecture is supposed to be to, I would say that I'll pull out a couple of them, three-ish, because it's some of them are overlapping. This is an area that I am highly interested in and have done lectures on before and done blogs and videos on, which can be found and freely available. These are things that are learned through simulation a lot of times, as well as in clinical practice with feedback. And I would say this, that the concept that I will talk about are really important, but they're not the only ones. So if you're interested, in contact me, or then we can talk about more of these concepts if you want, or check out the other videos that I've done on these. All right. So concept number one. This is a concept that usually is something that people have heard about in decision making. Let's just reduce the amount of information on this slide to begin with. So this is the model that has been adapted by emergency physician, professor in emergency medicine, and psychologist Patrick Croskery from I think he's from Dalhousie University in Canada. He's one of these people who are really interested in decision making and has made books. And there's a great book called The Cognitive Biopsy, which is case based. And if you want to learn about decision making in emergency medicine, this is a great book to buy. But in general, his model is adapted from that of Daniel Kahneman and Tversky, made popular by the book by the Thinking Fast and Slow book. And in general, the idea of the system 2 and system 1 theory goes like this, or dual process theory, I think it's called. So when we make decisions, as it is relevant to disease presentations, then either we have some kind of puzzle. Gary Klein, another cognitive psychologist like Daniel Kahneman, talks about like when we are approaching a problem like this. He talks about it's not like piecing the puzzles together. It's like having 6 different puzzles where we don't know what like we don't have the frame. We don't know how the picture should look like, come out in the end. We have 6 puzzles mixed together, and it's not like just like piecing the puzzles pieces together. We need to find out what counts as a piece, and that's why I again and again emphasize the importance of doing good history, being a good like clinician in assessing the pretest probability before we order tests, before we do an examination, and kind of knowing that we cannot do all tests because of opportunity cost and it's just ineffective. And there's a huge like expertise in this, and that you will not gain from going through these lectures. This is something that we learn in clinic through side-by-side learning for NESIS. Okay. But we have some kind of problem here. We have this patient with some kind of presentation, and either we recognize what it is, or we think we recognize what it is probably a better way of saying it. And then it's all right. Then we go on. Then subconsciously almost we go on system 1, which is not really thinking, but more of a pre-reflexive thing where we like pattern recognize, and then we from that go directly to diagnose. Oh, I think this is a diagnosis. The other way, if we don't know it, and usually if you're a medical student or more novice in an area, you more often find yourself here. You don't know really what it is, and that's where you want to do where you do like a bottom up kind of way. You go through all systems, or systematically you kind of you want to do an analytical probabilistic way of thinking of what are the risks here. And also if you're an expert and you don't really know what's going on, then you also go to system 2. System 2 it's analytical, it's more laborious, it takes much more energy, and it drains you, whereas system 1 doesn't really drain you as much. And that's why when we're tired, we fall to system 1. And there's no difference between there's no system 1 is not better than system 2. System 1 is they are symbiotic, right? So this one requires energy and is not necessarily more precise if you know what the pattern is. But if you don't know what the pattern is, it's a better tool to use oftentimes. So it's different. It's better thought of as different tools for different times. The problem is that we are not always in a condition where we can use or choose which tool we want. We almost always at default at this system, right? And that's good for the most part when we're living our lives. But in diagnostics, we may falter to what we call systematic biases, like premature closure. We might think that the patient who has been vomiting, who's 90 years old, just has gastroenteritis. I've seen gastroenteritis before. I know what it looks like. And then not think about that it could be something else than gastroenteritis. It could be some of the time-critical conditions. So that's the problem with system 1. Sometimes it premature closes you. One of many problems. And system 2 is also have problems. But I think it's always fair to say that system 2, there are 2 schools of thought here, and I've made an entire video on this as well. But there are 2 schools of thought. Either you are system 2 heavy, in your like Daniel Kahneman and Tversky are kind of they did their studies, their experiments in which they talk about in the book, Thinking Fast and Slow. They did their experiments in non-experts. They did different experiments where we could trip up our system 1 in situations where the participants were not expert. They had practiced the thing that they had to do for hours, maybe, or maybe less or more than that, a bit more than that, but they were not experts in their fields, right? They were not experts at it. And the problem with that is that, yes, you can find things that can trip up our system 1, even if you are an expert, but experts are much better at calibrating if the system 1 trips up. They see, oh, this is a pattern, but we did this and it didn't really work. We did this diagnosis and then we did this and it didn't work, or there are some faults in the system one, the pattern is not totally clear, we may have to do something else. Like and that's the other. So that introduces the other school, which is Gary Klein, and he has the book called Streetlights and Shadows, which is great if you want to have the counterweight for Daniel Kahneman's how to thinking fast and slow. And Gary Klein, he did his science in experts in their fields. I guess he's a cognitive psychologist and a scientist in expertise. Like he studies experts, and he has studied chess players and physicians and ambulance people or firefighters and so on and so forth. And what he finds is that system one is really, really important in almost all of these emergency situations. And if you're an expert, you have really good recognizing skills called mental maps that we'll go into in a little while. And through your deliberate practice becoming an expert, not just by exposing yourself to things, but also actually reflecting and practicing the things that were hard, that's deliberate practice, then you've added on in these mental pictures or mental models or mind maps. And after a while, you have a really, just like your illness scripts, your system one is very mature in certain conditions, and you kind of know the nuances of not falling into the traps as easily on premature closure. And if you force an expert to go to system two, then they become less efficient. All right, you may already start to notice why this model is so vast in its reach and is so important. I've only scratched the surface of this. And I just wanted to go through a few bits and pieces of this, and like here's where they talk about why you have certain things in system one and why you're certain things in system two and how you can upgrade your system one, like or system two. If you're good at critical thinking, like probabilistic way, then your system two is probably better. If you here is more like experience and gender and personality and so on and so forth. Like yeah. And this highway to the decision is meant to say that it's really easy to go to this like calibration through the system one. This is not a highway, this is just one street. So there's a high speed and almost unreflexive. Like it's not almost subconscious that we do this. And that's good for the most part. Sometimes though, we do need to become aware that something is happening, and that is one of the problems. Like, how do we become aware that we have to step outside of our usual routine and say, oh, something is wrong here with this patient, that is not working as good as it should, and that we have to be. That's one of the non-technical skills in emergency medicine and in critical care, right? So, like we need to be able to step outside and say, whoa, stop. Are we doing the right thing at the right point in time? And that's like almost mindfulness kind of. How do we know when we are supposed to do that? Because we cannot do it all the time because that's time inefficient. We have to do it at certain points. And one of the solutions is the concept of forcing strategies that I'll go through right away here. One last bit here until we move on is the system two. System two, if you do deliberate practice and learn, and sometimes overlearn and practice the things that are hard, then they will become second nature to you, and then they will become system one processes. This is what we want sometimes. We want this like mindfulness, almost rational override. Sometimes it can be conscious, sometimes because we may have forcing strategies, sometimes it can be unconscious. Not if we have forcing strategies then, but more like, oh, I saw this in the patient that was mismatching the pattern. It didn't really, it was the pattern to begin with, but then I did this and it's not really consistent with the pattern, so I have to rationally override. I have to look at system two again and see like, okay, what kind of differentials do I have? What are the time critical conditions, and so on and so forth. Or if you're in critical care, as we'll talk about, what kind of syndromes is it? Is it shock? Is it like, and then go through your mind map of that. So system two can maybe be thought of as a policing, like for the expert at least, it's like a policing guard dog that is guarding the system one and making sure that just calibrating our decisions. And the thing is about this calibration thing, it's like a battery because it drains your energy, system two. So it's much more energy demanding to use system 2, so you only use it sometimes. And if you're distracted, like someone asks you for a different ECG while you're doing this process, then you will have what you call a slip, and then you, even if you're an expert, you will you will lose your track, lose your thread, and then not come back to it. That's something, and that's why you should not disturb someone who's doing a medical list, or you should always do what you call followership in emergency medicine. You should always think, is this information that I'm now disturbing the team leader with, is that important enough, or should I wait? Yeah. There's also like about sleep and rest and decision fatigue, like all of these things, the focus, your cognitive overload, your resource availability, and so on, affective state, if you've been having a bad day at home and so on. All of this drains your system too. So when you're in the middle of the night, then and you haven't slept, you haven't eaten, and there's a really busy shift, then your system 1 is the overruling system, and your system 2 is not working as good. Then you need to have not subconscious. Then you cannot probably rely on your subconscious. Then you have to rely on forcing strategies or asking your colleagues about, can you please just talk with me about this case, because right now I'm not working. That's perfectly fine thing to do during the night. And some studies actually suggest that we should do that always because of these mechanisms. Okay, and like they're doing in radiology, you also always see 2 radiologists looking at this one picture. I don't think it's attainable in clinical medicine, but or in emergency medicine, but something to think about, and you have to pick out the cases where you need to discuss. And the forcing strategies that are more active, we have been through. If you like, you can say like, oh, you have a patient who has chest pain and you think it's ACS, but there's something wrong with your picture. You like, it's not what you think, or what are you going to do if the CT scan is negative? Or you can ask, the pretest probability wise, what is your pretest probability? Okay, it's 40% for ACS. What is the next, like, what? Okay, so there's 60% that is chance that is not that. What differential diagnosis does the 60% consist of, and are they dangerous? Like, are you over a test threshold for those things as well? That's a way of thinking about it as well. And show me 3 tests that are the most important, and that's also a test or forcing strategy that we went through in the case in part 1. And what if the test is negative? Like, what are you going to do if the test is negative? What are you going to do if the test is positive? These are like forcing strategies. Another forcing strategy that I haven't written up is just doing your 2x2 table, and just, what are the time critical conditions here, and have I ruled them out? Yeah. So I think that's what I want to talk about. That's all I want to say about system 1 and system 2, or the dual process theory. In general, this is one of the concepts that is so central to decision making, and it's attached to this are the concept of biases that we'll go through next here. So we can say that the more, this is from a paper by, I can't remember, I think I have the reference down here, but the more resuscitation of a patient, of a critically ill patient, is more of a system 1 game than a system 2 game. You don't have the time to go into analytical mode and think through all your steps. You do your ABCs, you gather your information, you treat, and instead of kind of knowing exactly what you're treating, you're doing this, what you call, you get some small data points that becomes a picture, or what you call a syndrome, and you try to treat that syndrome. And if that syndrome doesn't, is not treated the way that, is not responding the way that you would think, then you'll kind of gather more data, or then you kind of stop and see, okay, let's go step back a little bit, and get some more data, and think, yeah, we have to move the other way. That's what you call an iterative hypothesis testing process, and that's kind of what you do in system 1 in the non-analytical mode, and that's where we are most of the time in a really critical ill patient. I guess most of the patients in the resus bay are not necessarily really critically ill, but the ones where they come in with where they're dyspneic, or they're like really shocky, and they have a lot of they have a lot of like they're sweating, they're maybe unconscious because of their shock and so on. They're in a bad way. They're in extremis. Those are the patients. And then you have the other mode that we just went through in the part 1, the analytical mode. And sometimes it's really good in the resource bay. Once you get to somewhere where it's not responding in the way you should, then you can stop and think. You can do the forcing strategies that we just talked about. What is the problem here? And good habits is important here, because sometimes good habits are more like, these are conscious, and the other ones are cues. They're subconscious. Usually like, oh, I saw this and it didn't match the pattern, but you cannot always rely on that during the nighttime. So habits are good. Having checklist or sign out or ABCs, systematics, and so on, or so on and so forth. Like having good mental models, or if I see this, then I have to check this list. That's how you like get through and become a more efficient and better emergency physician in the critically Bay Area. And here were the, if you want to know more about this specific topic, which is fascinating, I think, check out Gary Klein's Shadows and Streetlights, or this video by Scott Weingart called OODA loops and breath baking. And check out the Sarah Krager's ICU.edu.org, where she talks about this iterative hypothesis testing process. And this one was from this one, Al-Asri, How to Think Like an Emergency Care Provider. Okay, so in general, when we meet a patient, this is from Eric Driver, an emergency physician in Lund. Who's my colleague and friend. He usually talks about, we have like, when we go to the diagnostic process, we have like step 0, 1, and 2. So the first one is like, get the data. Get the data is like Mr. Bean. And like, I don't know why, I've never been into Star Trek, but the SMAC community and the FOMET and so on, the internet culture have made Spock and Captain Kirk from Star Trek like something that often gets mentioned here. Because you gather the data, and then it's usually system 1. You have some kind of hypothesis. And then after that hypothesis have been like, you're doing the hypothesis, and then you have some kind of stop and think at some point, especially if it's going the wrong way. But sometimes just before you go out from the resource bay, it's like stop and think, sign out. What do we think here? What are we missing? Are we like, do we need something else? That's the Spock kind of really analytical brain that you have to turn on. Exactly. So the problem, or the expertise part of this, is having a well calibrated expert. If you have a well calibrated expert, then the challenge becomes not overusing system 2, like not overusing your system 2, but using it just enough so that you don't make mistakes. That's hard. So here was the cognitive biopsy by Croskery, and he has this. You cannot talk about dual process theory without talking about the cognitive biases, because those are usually the very human errors that we can make because of the system 1 and system 2 processes. And a lot of them are because of system 1, because we premature closure, or we don't gather enough information, or whatever. But the other ones, some of them are also system 2 ones. And here's just a framework that you don't have to go into. I go into this in another slide, or in another lecture on this decision making. But in general, a lot of these, like, something that we come across in the beginning of the interview with the patient. And oftentimes, if we go wrong to begin with, then we gather more and more of these, apparently, according to Croskery. So in the beginning, usually it's anchoring or framing or availability bias. Like anchoring is like we anchor on a specific information. Maybe the ambulance bay personnel or the ambulance said that, oh, this patient had had an anaphylactic reaction 2 years ago, and then when they're hypertensive now and they are red, then we anchor on, oh, it must be hypertension, it must be anaphylaxis, and we're anchoring on those data points. They're important. They are important, and we probably should treat it, but we also shouldn't become sticky to that data point. We should be able to like with Teflon, like have it in our hand and say, okay, we treat it, but we are still keeping our eyes open for other things if it doesn't respond in the way we should. That's anchoring. And framing would be if it's kind of associated with if the ambulance gives you this report and they kind of frame it in a way, the history in a way like, oh, we found the patient at home and he had a seizure, and then we came here, and then they're kind of framing it in a way that, oh, this patient had a seizure. Wait. I usually like stop. What did you see? Then I'll decide whether it was a seizure, probabilistic wise, and like say how certain I am that it was a seizure. So okay, he had muscle movements and he kind of like did some asymmetrical things for a duration of 20 seconds. That doesn't sound like a seizure necessarily. So just but that's where you can frame someone. I can also frame someone some of you guys in the department if I say like, I have ruled out this and this in my chart, right? In the conclusion, if I say I've ruled this out, then I'm kind of framing you because you will not go down that path again, or you're less reluctant to do so. I'm very aware of how I write my notes and how I weigh my language probabilistic wise. Framing is a really important bias. And also, if you see a patient in the ambulance bay, or if you see on the surgical part of the emergency department, or if you see it on the orthopedic part, or if you see it in the resus bay, I'm sure you will treat that patient differently. And that's also the framing effect. And so on. Like there's lots of these, and like these are biases that we all are prone to, and I don't have a solution to them, but I'll show you in the next slide. The snowball effect, as Kassirer says, that you pick up more and more if you go wrong in the beginning. Another reason why you should sit down with your patient and get a good history, so that not to anchor, frame, or get premature closure. Be non-judgmental to begin with, and just know that there are other factors, but just listen to what the patient is saying before you wind up your brain and make up your mind. Yeah, and here are all the cognitive biases in another slide. But what I want to say about biases is that oftentimes we only hear the one side of the story, or you shouldn't premature close, or you shouldn't do this or do that. And that's true. It's like biases are a byproduct of the way that we think. And sometimes that is unfortunate in the diagnostic process. But oftentimes it's important to premature closure. We shouldn't because the other side of that coin is opportunity cost. So if we spend or analysis, paralysis by analysis, we are using the analytical mode too much. We cannot make decisions. We cannot you're anchoring on some information. Well, you have to kind of have some information, some data points that are a bit sticky. Otherwise, you'll just not be able to use any data points because you don't value any data points more than others. That's also wrong. So I encourage you to not see biases in an unbalanced way, to try to design your way of thinking and your clinical way in the emergency department, but also in your ward rounds, so that you have good habits on using system 2 appropriately. Like in the emergency department, it's good to have these forcing strategies or checklists. It depends, right? But just knowing that with all of these, premature closure, when you hear hoofbeats, or don't think of CPRAS, errors of commission, like you've done, you didn't do enough, and Occam's razor, like the most common, or sorry, the I cannot remember the exact wording of this, but it's like the most simple explanation is usually the right one. Well, the contrary to premature closure is paralysis by analysis. You need to do some kind of information, like the contra to when you hear hoofbeats is separate retreat. like, oh, so you should actually like separate retreat is not thinking of separates because they're too uncommon. Well, as I said, separates do exist and they are common in the emergency department, just not the separate that you're thinking of necessarily. So you can think of the separates sometimes in the right circumstances. Errors of omission that you didn't like. Here is like you did too much, and here is you didn't do enough. And Hickham's dictum, like Occam's razor, the other one, like the simplest explanation is usually the right one. Hickham's dictum is the patient can have as many damn conditions as they want. And the code here is like this is like kind of a yin and yang, and Catherine Montgomery talks about this in her book as well, about this contradictions in our clinical thinking, and this is just how it is. It cannot be any different, and we need to be aware of that. But what is like really important is that it is context dependent. Doing premature closure you need sometimes to do premature closure or anchor on some points of information, especially if the patient is critically ill. You have to do something and then do something, and afterwards then you can always analyze, right? When you hear hoofbeats, well, I mean, yes, it depends on the history of the patient, and you shouldn't necessarily think about but once the CT scans are normal and this was different and the patient is a different population, then okay, it may be a zebra. And errors of commission, that you're doing too much, and omission, you're doing too little. Well, Weingart would argue that, well, in the resource bay we should probably do more, and because then we don't have enough data, and it's really early in the disease stage and the diagnostic process, do more then, and then do less later. That's the truth with modification, though. And Hickham's dictum, well, we talked about the elderly patient that usually not have one condition. Occam's razor, 100%, but they may have several conditions for their symptom, right? Hickham's dictum. So it's a balance, and it's really context dependent. Okay, concept 2A. All right, so during the resuscitation of a patient, I usually say that there's two processes going on in parallel. You have your what you call treat as you go. You go through ABCs, where you gather data, where you kind of find where you kind of get a look at the landscape. What are the puzzle pieces in this patient, and what counts as a puzzle piece. And you do basics like basic treatments, generic treatments. So low blood pressure if it's not a trauma context, then you give some kind of fluid. Low oxygen, then you get a oxygen mask on, and so forth. Like it's generic. It's not something specific to the condition. But then as you gather data, then you'll get more and more of a pattern, and then you will be making decisions that are more specific, like the bowman here, or the archer. There's this Buddhist telling about a archer that or a man who was hit by an arrow, and he didn't want to get the arrow out until they found who not killed him, but who shot the arrow. Like, you don't want to treat anything before you know what kind of condition it is. Well, in the time critical scenario, that's a mistake. You need to try to treat specifically, because if you keep treating your patient who is hypertensive with water, and you don't realize that they also maybe have another condition that you like a tamponade, or you didn't think about all the other shock conditions, then it won't help. So you need to gather your data, and then a pattern emerges that you have to treat. And then as more time goes on, then another pattern may emerge that may say that this prior specific treatment was not quite good enough, but that doesn't matter, because at the time it was the right thing to do, right? And balancing when to have have a cold head and gather more data, and when to actually treat something more specifically, depends on how reversible the treatment is and how dangerous the treatment specific one is. So my example is usually adrenaline is usually something that doesn't kill anyone ever. at least not in small doses and not in the emergency bay. So give adrenaline if you think if it's hypotensive and you think it's anaphylaxis, then try to give adrenaline and take a tryptase to confirm the anaphylaxis thing afterwards. But and it's reversible and it goes out of the body and doesn't really cause that much harm. Another example, the contrary example would be thrombolysis, right? If you're going to give alteplase to someone who has pulmonary embolism with hypotension, then you kind of want to make sure that it's not an aortic dissection or anything else. And that's sometimes you may not be able to do that, and then you have to make the decision. But that's a more hard decision. That's where you maybe want to have more data before before you kind of know. Maybe you want a POCUS on the chest to see that they have a right chamber failure. Oh well, okay, that makes sense if it's a young person and it's not a person who was known with right chamber failure, right? So the more reversible the treatment is, the specific treatment is, the better. The earlier, the lower the threshold should be to use it. We can use it. We can see this in another way. Like if you have three, it's like Eric Driver sometimes talk about this. Looks like a pattern in the sky, right? A star sign. So if you have the data points create star signs. So you have 3 data points here. You hear stridor on the patient. You see that they're red and they have low blood pressure. What is the syndrome that we think this might be? We're not sure what diagnosis it is yet, but the patient is really in a bad way. We need to treat now, and oxygen is not doing it for us. Yes, could be, as you may be thinking. Well, first of all, they might the low blood pressure and so on. They might be in shock, and what could that be? Well, it could be. It's probably anaphylaxis. I will treat first. Also, adrenaline helps for the other ones as well, so it might as well give it. And then another data point comes along after we've given it, and they also have fever. Then sepsis goes up a bit, but that doesn't really matter because it was reversible. The thing that we gave, and it's So that's kind of the way we think, and that's why in the beginning of it's more of an iterative process when there's a really high time factor than it is when we're outside of the critical care area. Yeah, and just to remind us that when we are here in the beginning, especially with critically ill patients, then it's very likely that we will find out information tomorrow that is much more precise, and we don't but we will still, if you have a hypersensitive patient but they don't have fever and you don't know what's going on, then I have a low threshold to just give them antibiotics, because one third of elderly patients presents with non-fever in sepsis and so on. On the risk benefit side of things, I might as well just give it. Depends, but yeah. And that's why did they give them antibiotics? It's clearly not that, but that's only something you know after the fact. And my errors are measured by what I do right now with the data that I have right now. Just another picture from Sidney Dekker, who has this great book called The Field Guide to Human Error, and he has a YouTube channel where he goes through his books in much faster than I do with my lectures, and he's really good. And so if you wanted to know more about failure culture and second victim and third victim and so on, then and hindsight bias, check out those. But in general, this is just a picture that shows that the patient, from our perspective, from the frontline clinician's perspective, before the accident, there was lots of different data points and which one carried the most weight and should we do this or did that. It's a very complex thing that I'm trying to describe here, right? But once the mistake was made, and someone who's looking back on it, saying, okay, there was a mistake. Why didn't you just go? It was obvious this was the mistake, right? Why didn't you go that way? Well, it's not as simple as that, right? When you look at it prospectively, ask, and you also have to think about it in context, right? What kind of context was it? What kind of resources was there available? What time of day was it? How many patients had you seen already? Take that patient and then add 10 other patients with the similar symptoms, right? Which one would you want to work up? Which one not? I don't want to do CT scans on all of them. Which one should I choose? You tell me. That's why we are the experts on this, and we should definitely learn from our mistakes. But we should not blame. We should learn, right? And looking back, like with a hindsight bias, saying, "Oh, we should do like this." It's obvious. That's missing the point. Okay. So just to hammer that home, there's this great blog here that you can check out about this. But in general, we should be caring about the decision. Why did we make the decision? What kind of data points were we weighing? Could we have gathered more data points in the time span that we were doing it? Because we want to, like, we do care somewhat about the outcomes, but not as much as the decision. And what kind of, like, how do we make the decision? The problem is that you can make a really good decision and still have a bad outcome, because most critically ill patients are critical. I usually talk about patients being like penalty kicks in football. Like, some patients are penalty kicks. You're not supposed to save it. It's a high chance that you don't. Don't be sad if you don't. Do your best, right? Because a lot of people are critically ill, and you will have bad outcomes, but sometimes you may be able to save them. So it should not be the outcome that is the measure of success here. At least not entirely, and probably should be a minor thing. And on the flip side, you can, like, you can send home a thunderclap headache patient without doing anything. 90% of them will do fine, right? That doesn't mean that is a good outcome, but that doesn't, because they were safe from the radiation, but that doesn't mean that's a good decision. It was not a good decision based by the data that you had. So this is a really important thing. Process is much more important. That's why we go through process in the cases, not outcome. I don't care what the outcome is. I want you to argue, why did you do as you did? And always think that people are competent. Why did this expert do this? What was it in the context, or the thinking, or whatever? Like, what was it that made them do that? Because if they could do that, I could do that as well. With that, like, just go through a case prospectively, where you give people a little more data, then you will find out, without giving them the result, then you'll find out that most times it's not black and white what we do. It's very much how we weigh different factors and so on. So learn, not blame, is the thing here. It's process, not outcome. And we should be humble and think of think of the person as competent. Like, why did that decision in this expert doctor make sense at that time? And if you want to evaluate it, there's lots of videos on that. I can link to that later. But give 10 similar cases to people and see how they would perform, like 10 chest pain patients, right? Do it prospectively. Yeah. And this is from Catherine Montgomery, right? Gross measures of patient outcomes are misleading because the correlation between the exercise of clinical judgment and the patient's subsequent health is poor. Poorly treated but healthy patients often make a good recovery, right? Could be a bad decision made, but have a good outcome oftentimes. And well-treated patients with serious ill conditions often die. This is Patrick Croskery. Sorry, I distorted the picture a little bit. He says that the failure rate in emergency medicine is 15%. He often talks about emergency medicine being the laboratory of error. And usually there's 3 reasons for the diagnostic failure. Either it's knowledge failure, which you think is minor. It can be error-prone conditions, like that's a big thing, like the environment that we work at, the work schedule, the time of night, and so on and so forth, right? And then there's thinking failures, and it's suboptimal data gathering or interpretation. And that's why the interpretation bit is what we went through in the part 1, and gathering data is like what I talk about when sitting down and talking with the patient, with illness scripts and so on. Yeah. He would say that 75% of these are like the reason why we make these 15% errors. On the flip side, this is Eric Driver. And he would say that the knowledge failure is probably a bigger part, and he focused on checklists for that reason, because he thinks that there are so many novices in emergency medicine, non-emergency physicians, that they don't know what they don't know, and that's maybe true as well. And cross Carisian North American, he works in a different system. Maybe in Scandinavia that is the case. But this is important. Eric says, like, failures to approximate the probability of sign-sensitive conditions based on available point-of-care information. That is a diagnostic error in emergency medicine. That's what we've been going through here. Okay, concept 2B, and this is 2B because it's connected to A. It's overlapping, and we talked about in 2A about the syndromes that we want to specifically treat as we gather data and find patterns that are not yet a full diagnosis, but are patterns that are good enough for us to be able to specifically try a treatment and see if it works in the critically ill patient, where we have not enough time to get a full diagnostic evaluation. And that's, for better or worse, like, probably most of the patients that we actually see in the emergency department have this time problem, but not all of them are as critically ill. So if you have someone who's dying in front of you, it's more relevant than it is whether you have 4 or 6 hours on you, but you still have the time constraint. You still need to think in this way in a lot of in a lot of sense, as opposed to in the ward where it's less so time critical, unless they're in a bad way, and then you can usually wait until the day after tomorrow, or the tomorrow, where you can, like, get the blood samples, do some diagnostic tests, and then see what falls out after that day has gone by. A luxury that we don't have in the emergency department, and that's why these concepts are important. I'll give you this next concept as well, which is connected to that first concept. So here we see 2 patients, which I know this is from a ward, this is a stock photo, but this is not a stock photo. This is from a YouTube video where they have a patient who had a knife to the chest. It's really like kind of a unicorn of a video, because there's a good team of documentaries out, journalists out filming this hospital when a really rare condition comes in, like a stab to the chest, which isn't uncommon, but they managed to the patient gets a cardiac arrest. And if you get a cardiac arrest after a stab to the chest, then it's either a pneumothorax or a tamponade. That is highly likely. It can be other things as well, but they see that there's a tamponade, and he becomes really he goes into cardiac arrest, or I guess a low flow state would be a better term for it, but clinically cardiac arrest, as we still use that terminology. But what is fascinating is that you can see through the entire video. I think if you search Google or YouTube for tamponade or acute thoracotomy, then you can find this video. It's from an Australian hospital, I think, maybe English-speaking hospital at least, and you can easily see how the patient is deteriorating. He's sweating more. He's becoming worse and worse in front of your eyes. And the thing is with this patient is that we have this thing where we may know or may not know what is going on, but we know that the patient is sick. And that's what I wanted to introduce to you. Our syndromes doesn't have to be specific, that we don't have to know what it actually is. We just can categorize the patient as being sick or not. The same way as we can categorize a patient who is not critically ill of being like you are an admission or not. We have thresholds for that as well. Just like we have the treatment threshold, we have an admission threshold. Even though we don't know what the reason is or what's wrong, sometimes, especially for instance, elderly patients, well, no matter what the cause is of your problems, I don't know what the problem is, and it's maybe even isn't a time critical condition, but if you cannot walk home, then you cannot go home, right? So that's an admission no matter what kind of test you do. right? So we have these I don't know what to call them actually, but it's not, it's kind of clinical syndromes, but they don't necessarily have anything to do specifically with the pathophysiology. They have something to do with the context and what, like, is it an admission or not? Is this a sick patient or not? Right? So these are also like parallel syndromes that we need to kind of know about, because then we need to know how to react. If we have a sick patient that we don't know what to do about, then we have to call down people to help us, right? We need to call in someone who can actually help us. That might be an emergency physician specialist. It might be an anesthesiologist, depending on what specific problem they have. And to kind of getting to know this gestalt, how to looking for what is important, is something that you can practice in emergency medicine, and try to go into like Simon Cawley has done this lecture on this area about how to become better at our intuition. And he asked us to go into a emergency critical care room, akut larmrum, and don't look at the monitor, just look at the patient and decide for yourselves, are they sick or not? And usually the reason why they're sick, or you consider that they're sick, is usually because of some key clinical features. And oftentimes it's one of these things that if you're not looking for them, you're not picking them up. So oftentimes it's because they're sweating, or the way they're sitting, or the way they're breathing, the work of breathing, or the way that they're like there's so much data, and we often look at the screens instead of actually looking at the patient. I do that myself all the time. But this reminds us that it's actually important to don't look at all of the vital signs. Don't look at the blood samples. Look at the patient. How they do they look? Do they look sick or not? And if they don't look sick, then you're probably fine. You have some time to find out what's wrong and decide whether or not to go in or not and do something about it. If they are sick, then you have trouble, especially if you don't know what's going on. There's this score called the Weingart LLS score. It used to be on MedCalc, this homepage for scores in medicine, but I think it was taken off. It's called LLS, like looks like shit score. So it goes from, it's 1 or 0. So this patient is 0, this patient is 1. Doesn't mean that zeros cannot have dangerous time-sensitive conditions, but they are not urgent. We don't have to throw ourselves at them right now. But these patients are peri-arrest. We need to do something now. Exactly. Usually, why we think that they're in a bad way is usually because they sweat, they are cold and clammy, they have tachycardia, they're lethargic, they're tripoding the way they're sitting, right? They have a high work of breathing. The look in their eyes, like what you call the look of doom, and how good they are responding to our questions. So there's lots of like non-specific vital or vital signs that are not on the screen that are really important, and I just wanted to draw attention to that in the emergency room. And if you want to know more about that, there are several references I could give you, but one of them is icuedu.org by emergency physician and critical care physician called Sarah Krager. She's done these. She's done a lot of videos, and she in between all of her videos, she talks about these, like her spidey sense, or like, and that's one of them. Also Gary Klein's books and videos. And also Scott Weingart's OODA loops and bread baking. These are just a few examples of, and maybe Simon Carley's lecture on can we teach clinical gestalts is also a good one. So all of those like kind of show us how to teach these things, and be aware, like Sherlock Holmes, seeing what others don't when we enter a resus room, and actually being able to gauge whether the patient is sick or not. That's a really important skill for emergency physicians. Yeah, here are some of the. Okay, so we can do another 2x2 table here, as I was kind of alluding to already. You have looks like shit 0 or 1. And then you have, I know what this is. You kind of know the pattern. Oh, they look like shit, but I know that they are anaphylactic. Then no worries. I'm happy about that. I'm not worried. Or, okay, I was called to a patient. They don't look like shit. Okay, I'm happy. They're not really in a bad way. But if they look like shit and I don't know what it is, that's a problem. These are scary patients, right? This is where you really need some more hands on deck to see what is going on, and stabilize them so that they can get that diagnostic test. Here, it's also a problem. This is mainly where we are all the time. They don't look like shit, but we don't quite know what it is. This is where we have to gauge our probabilistic thinking and use our probabilistic thinking. Here, I know what it is, and they look like shit. Well, I have to make things happen. That's what I also teach about non-technical skills. That's the difference. Like, being good at your non-technical skills is the difference between actually knowing what to do. I have a list, I know what to do, and actually making them happen. Like saying to the nurse, like, do this and come back with a closed loop to me. Being the leader of the team to make it happen, knowing beforehand where all the things are that you need in these situations, having visualized and drilled these things in simulation and in your own head, so on and so forth. Those are some of the non-technical skills that are so important. And then remembering slow, smooth is fast. You don't have to hurry when you're doing something. That will usually make it worse. But doing it smooth, doing it slow but meticulously, and doing it right is usually something that gets you much faster to the target in mind than if you do it too fast. All right, so do it and do it slow. Slow is smooth, smooth is fast. Amateurs talk strategy, experts talk logistics. That's also a Scott Weingart quote, or a military quote it is as well. And it's all about, what I just talked about. Like if you have a list of 10 things, the amateur would usually say, oh, I know the strategy. I know like there's 10 things I need to do here. And I just do that and do that and do that. But they don't know how to actually make it happen. Experts talk logistics. How do I make it happen? Like I need to know where that is, and that's a difference. And I believe that lies in the non-technical skills. And in opportunity cost, have you talked about? Yes, you can do a lot of things, but I want to do which things are really important right now. That's the important thing. So that's how we can do when we know what happens. Here, if we don't know what is happening, we don't know the pattern, but the patient is deteriorating in front of us, and we don't know why. Then get help, buy time. All right, we need to buy some time. We need to go back to an advanced algorithm, or sorry, not an advanced algorithm, but an advanced like basic ABCDE. So if they're not doing better on oxygen, then we need to put on the NHF or high flow oxygen, or we need to give them an IV. If that's not hurtful for them, we can check that quickly if they don't have pneumothorax and so on. But we need to buy time so that we can actually get to diagnose them a bit more, get more data. Or maybe we have the data and we don't understand it. That's usually the schism, that we don't know whether either we don't have enough data if they just came in, or we don't understand the data that there is. We're not expert enough, and that's part of why we not want to get help sometimes if we're not seeing the entire picture. And then treatment like in this iterative manner. Like we try this and see if it helps. If that doesn't help, then we try this. Like be continuously trying to reevaluate the patient in this iterative manner. Okay, concept number 3. Mind maps. So mind maps is also like a cognitive psychologist's kind of way of describing the pattern recognition that experts have. So when an expert looks at a patient, they will see a pattern that lines up with a specific diagnosis oftentimes, or at least a syndrome, and they will treat accordingly. But if they don't know what quite is happening, then they will revert back to their mind maps. And mind maps is this kind of integrated way of thinking about a specific problem that is evolving as you become more and more expert. You have more and more nuanced mind maps as you become expert. And that is one of the definitions of experts, that they have more and more nuanced mind maps. And you develop these more nuanced mind maps through experience, but also through deliberate practice and actually asking yourself, why did that? Could I have done that better from those that data that I had? Like when I quote unquote missed a necrotizing fasciitis, then I went back and asked my colleagues, like, could I please discuss this case with you? Yeah, what would you do if this and this and this happened? And they kind of asked the same. They did the same thing. And this is going into feedback theory, but only if they say, like, maybe if only 2 or 3% of what they're saying is true, then I can use those 2 or 3%. I don't have to. I have an entire different video on how to get feedback and how to like kind of develop this deliberate practice skill, and have a growth mindset. I'm not saying that I have that I'm an expert in this either, but it's something that is really vital to know about and trying to get better at. So through this, my mind map might develop so that, okay, next time I see this, then probably I'll just nuance it a bit and do this instead. And I might do that instead of just admitting with IV antibiotics. I might just, if that pain is so serious, and then I would, like cellulitis would not have that kind of pain. Okay, then I would be more reluctant, just more prone to just, okay, putting that knife in and seeing if there is some fluid that underneath there that is actually like dishwater. Like, so that's how we can update our mind maps. And we also have, like, one example here is the mind map of if you have a C problem, if you have a patient with shock. Shock is defined like, so if you have a patient with shock, let's go through that. And a novice mind map would be like, oh, the patient has low blood pressure. That is shock, and that is not shock only. Like, you can have shock is defined as hyperperfusion, but for a novice, they would say low blood pressure. That means shock. That means fluids. That's a simple mind map. A more advanced mind map might be like this, which many of us kind of carry around, but maybe not use as much when we have someone who has undifferentiated shock, where we have to think about, like, okay, it sounds like anaphylaxis, but let me just go through in my head, what could it also be? Have we taken an ECG? Have we checked the POCUS for pericardial effusion? Have we checked that they are not hypovolemic, that they didn't have a trauma? Have we checked that they don't have anemia for dissociative kinds of shock, right? And do we have any other vasodilatory shock we could think of? Do they have sepsis? Are there any things that might suggest that they do have that? Should we treat that also? Like, that's a mind map that you fall back on if it's not going your way, or if the clinical picture is not quite overlapping with your illness script. And then as you become more and more expert, if you then you can check out ICU, EDU, and check out this very sophisticated mind map of how to check out or how to become good at shock, especially in the ICU or our intermediate care unit. So there are like different levels of this and different amounts of expertise depending on your journey towards expertise. Because, and just to set the record straight, shock is physiological. Like we talk about shock and this great picture, I think, about how is a good way to think about shock. We have us looking at a patient in physiological stress here. They may have low blood pressure is a late sign, and usually it's like being out running or out swimming. They will have tachycardia. They will be maybe a bit out of breath. They will be a bit more tired than usual, and so on and so forth. And as long as they're they may be tachycardia, they may be having fever, they are compensating here. When shock develops and they later develop an organ perfusion, then they cannot compensate anymore. they are not strong enough, or they're tiring out, so that now the lactate is going up. Now they're hypoperfusing their brain, so they're not being aware. Now the blood pressure tanks, just goes down, and especially in children, this is a really late sign. So, so we need to be able to know where they are on the spectrum of physiological stress or compensated shock to decompensated shock, right? They may still be hypoperfusing things here, but they're compensating for it. Here, it's going downhill. Yeah. Exactly. So the compensated one is they have physiological reserve, and that's better than the stress, right? And then they might be hyperventilating, they might be hypotensive, they may be hypotensive, right? They may be tachycardia, but they're not developing this lactate. They're not clone and clammy. They don't have a high shock index or delta shock index. They're not low in GCS and so on and so forth. So mind maps like this in shock teaches us to look at more than just the low blood pressure. It teaches us to look at more than just the high lactate. It teaches us to look at the entire patient, but it takes experience, and it takes knowledge, and it takes time to be good at this. And that's how mind maps develop and become better and more nuanced as you develop as a physician in a specific field. And here's just a close-up of the mind map I just showed you, where you have, this is usually what I kind of use. If you have someone who's in shock, and remember, if you usually have more than just one cause of this. This is Hickham's dictum, and not Occam's razor when it comes to the critically ill patient with shock. So hypovolemic. Well, could it be bleeding? Is it trauma? Are they responding to fluid or not? Do they have an empty IVC with respiratory variation and hyperdynamic heart? Or like, how much data do I have to say that they hypovolemic, to have they been vomiting, and so on and so forth? Arrhythmias, like cardiogenic shock, do they have any obvious signs of problems with the heart on ECG or POCUS? Vasodilatory, also kissing ventricles, right? Because if you're blowing all your volume out to nothing, no resistance, then you look like you're hyperdynamic, but you might be vasodilatory instead. Obstructive, do you have PECs, like pericardial effusion, or do you have right heart strain? Oh, and dissociative, do you have a low HB, or do you have carboxyhemoglobin? Okay. And then here is Sarah Krager's a bit more advanced 3 pressures model, where she talks about, well, we always think about the forward pressure, the map pressure, and you can have a good map pressure but still be in shock, because where the magic happens here in the capillaries, like the map is really good for getting the blood pressure to the capillaries, but once the blood is at the capillaries, it's other pressure gradients that are at work. And look at her entire like reframing shock lecture for details on this. But in general, you have 3 pressures. You have this pressure, you have tissue, like the external pressure, like if you are fluid overloaded or something like that, and you have the back pressure. And if you have too high a back pressure, like you're congested and you have fluid overload, then sometimes in the shocky patient, it's better to just give them fluid. Furex or furosemide or Lasix to drive off some of this pressure, right? There's different things you can do. Also, if you have someone who has a big who has a right-sided heart failure, then it's, even though they're in shock, it's good to not give them too much fluids, like Goldilocks amount of fluid, and then give them inhaled nitric oxide to vasodilate, so they don't have so much back pressure. And like there's a different way of thinking about shock, and not only thinking about the map, right? But check out Sarah Krager. She's a genius, I think. And then check out her video if you want to know more about this specific mental map. Yeah, and she talks about the unstressed volume, and we should get vasopressors early. But check out her lecture for that. What I actually wanted to talk about is the dyspnea, right? Because that's kind of the framework for this part of the talk. So if we talk about AB problems, someone who has dyspnea or desaturation and so on, a novice might be just, it's low saturation, add oxygen. The next one, and I'll go through this in big, in the zoomed-in version right away. The next one might be just what we call a dyspnea pyramid, where you have some kind of systematics to know kind of what kind of causes are there for dyspnea. One that I use much more now is putting, like, we can really quickly differentiate the dyspneic patient by doing a chest point of care ultrasound, right? So, do they have wet lung? Like, is it a dyspneic patient with wet lungs or not wet lungs? That's a kind of a good syndrome distinguish because if they have with wet lungs, then it's probably congestion. There might be some like B lines like there might be false positives for B lines, right? It's not necessarily not false positive. There are different differential diagnoses for scattered B lines in both lungs, lung fields. It may be pulmonary edema. It may be, but it could also be certain infections that looks like inflammatory processes. So it doesn't necessarily mean fluid, but it's just one way in the emergency room to do that. So like kind of wet lungs, dry lungs, and then try to gauge your treatment. Another way of doing it is also by doing the what kind of respiratory distress are they in? What kind of syndrome is it? Is it hypercapnic or is it hypoxic? Because that's really useful when you want to get a bit more advanced and do a treatment with NIV, non-invasive ventilation, or BiPAP as they call it in commercial terms. All right. We'll talk about these later here, and then for A problems, like to begin with, the mind map might be called the anesthesiologist when they have advanced air problems, airway problems. And a later stage would be doing a vortex method that we sometimes use in emergency medicine. I can go through that later here, and then for specific cases, you may have. For the anaphylactic patients who has an A and B problem, you will do an AMAX 4, for instance. I can go through that as well. So just to show you the mind maps for dyspnea, you have this thing called the dyspnea pyramid. Sometimes it's also this is one I got from the internet, but when I usually draw it, I usually do it also with time, like how much time has gone by since what is the onset of the symptom, because I usually think that variability is also really important in distinguishing these different conditions. But the pyramid works like this. In the bottom is what's most common, and then it goes up to the point of the pyramid with something that is least common. And I think it helps mostly because you think of lungs, yes, you think of heart, but sometimes when someone is dyspneic, it's actually because they're anemic. They may not be dyspneic in the sense that we think, but they may be tachypneic, like they're breathing a lot, like they're breathing very frequently. That might be something to do with the blood because they're anemic, or they have some kind of methylene intoxication, right? Or carbon monoxide intoxication, or it may be that they're hyper tachypneic because they have a diabetic ketoacidosis and they want to drive off their acids, right? Most times, so from emergency physician's perspective, you can get this from an ABG, and these you can usually get from POCUS. So that's like a quick, I don't like algorithms in the emergency room per se, at least not early on, but it's kind of a small like hint or mind map, I would call it anyway, to know what to do in the different situations. And then you have the differential diagnosis here, and you can, as I said, put them into different categories depending on how fast the onset is, because pneumonia is usually not something that develops over one day or just right now. It's something that develops over days. Aspiration is something that usually is quite acute, or it develops has an onset of like seconds to minutes. Pulmonary embolism as well, right? Like again, we're talking likelihood ratios here. There are definitely atypical presentations for all of these things that I just mentioned, but but we're talking likelihood ratios, right? And and they forgot to bring in mechanical and neuro airway things here. So that's also usually added. If you have a mechanical slash neuro thing, that might be Duchenne's muscular dystrophia or myasthenia gravis or something like that. Airway management problems would be an upper airway problem, just like anaphylaxis or foreign body airway obstruction. Okay, so the take-home message with all these concepts is system one, like for emergency, like for critically ill patients that are LLS 1, system 1 is better than, or is the way to go more than system 2, because with system 2 you will analyze, you don't have time to use system 2. You need to know and like think about what to do before actually getting into the thing and practice that. But we need both, because system 2 is needed when things go wrong or we don't really know what's happening and they're not responding in the same way that we should. Then we fall back to our mind maps, which is not quite system 2, but almost system 2. It's like a practice version of system 2. I practice my mind maps, or practice the way to approach a patient with these problems, these syndromes, right? The dyspneic patient with wet lungs, I would put into NIV, right? Because and give nitros, for instance. But I might fall back to, oh, they're not responding to this treatment. Then I will think, well, it could be, maybe the lungs aren't wet, maybe it's inflammatory instead, and the B lines are actually because of that. So it depends, right? But so we need both, but more one than two in the critically ill patient. And that's why it's really uncomfortable for newcomers or novices or new doctors to actually be in this situation, because they don't know. They haven't thought about these things and they haven't been in this situation before. So yeah. Then specific treatments before diagnosis is crucial. Like this is the Archer thing. We don't want to treat the anaphylaxis with water all the time, even though our first approach is like these two parallel approaches. Like we have the generic approach where we just low blood pressure, give water or give fluids. But once we gather enough data to actually manage syndrome, then we'll treat the syndrome, like especially if it's a reversible treatment like adrenaline for anaphylaxis. Okay. And then if you have someone who's LLS1 but you don't know what it is, buy time and call for help, right? We want to buy as much time as we can to maintain their life until we can know what it is. Yeah, but how? Well, the thing is, and this is the last concept, and it's not really the topic of this thing, but it's a non-technical skills. How do we actually get to do all of the things that we need to do in order to save the patient's life in the emergency room? Because it's really stressful. We have this thing called the Yerkes-Dodson curve, and if you want to check out like Dan Dworkis' book and podcast and video on on these things, I highly recommend that. It's all about performance under pressure. How do we keep performing under pressure during these stressful events? Because if we are in the red here, then our performance is usually called the performance arousal curve. The stronger our performance is strongest when we are in not too low arousal, we're not bored, and not too high arousal, we're not like shitting our pants, so to speak. We're in like this green zone. So sometimes if you see a patient that you haven't, like a syndrome that we haven't seen before, or like what they usually in America called, like it's a sphincter tightening case, where it's, oh, I don't know what to do here. There's a lot of non-technical skills to like make your team work, but if we just talk about performance under pressure, then we want to left shift our curve, as we said. We want to, if we are stressed, then we want to left shift our curve to the left, and we do that by doing some things. Right now, when we're like we need to be acknowledge that we are in the red zone. Okay, I'm in the red zone. What do I do? Well, there's this called BTSF, Breathe, Talk, See, Focus, and you can learn more about that from Mike Loria. Or you can, and at home after the case, you can visualize the case and try to go through. You can also learn more about that from Dan Dworkis and Mike Loria. You can do stress inoculation, where you actually go into a situation like next time you're working out, or you really like have a high pulse, then try to think about what to do in such a case. Remember the case that you had last night or the day before, and see, what are you going to do now? Especially if you can do it with someone else, that would be great, right? Develop your mind maps. Think about your approaches prospectively. Don't be satisfied about, oh, it turned out to be a pulmonary embolism. I was right. Like, why were you right? Did you do what you should do in the situation with the information that you had? I don't care if you had a lung pulmonary embolism. I care if you made the right decisions through because of the with data that you had, and did you get the right amount of data at the right time? And you can always develop like what if scenarios, like what if this happened? Okay, let's say that the patient came in unconscious, but what if they were 90 years old, or what if they were pregnant? What did you do? What would you do then? And you're going to CT scan. Okay, what if the patient suddenly seizes? What were you going to do then? And this that kind of helps us to be creative about both our mind maps and our plan and our ability to like fly ahead of the plane, but also in situations when we are doing simulations, kind of pressing people on, like pushing them out to the right side here, and then they have to gain control again and get to the left through maybe cognitive deloading. You do this, and I think of what to do, or on any other skills. This is just a really, really quick and dirty talk through like performance under pressure, but check out these links if you want to know more about that. All right, let's get to a case from an emergency room and with the dyspneic framework. So this is a patient. In 2 minutes, you'll be getting a patient who's 52 years old, who's a frequent flyer, it seems. He has asthma and psoriasis, asthma maybe COPD, it's kind of unclear, alcohol abuse, and he takes these medications as are here. And he became short of breath 2 hours ago, and the ambulance have given him 5 milligrams of Ventolin by a nebulizer, and he's coming in. So there's different ways of doing this. This sign-in is done by an SBAR fashion, the SBAR situation. So what kind of team do we have? They all introduce themselves. So, hi, my name is Peter. I'm the team leader, and then the nurse and usually the nurse's assistant will introduce themselves. And then I'll say, okay, I have a 52-year-old man with a shortness of breath who will be arriving in 1 minute. I'll just so we know he has asthma, psoriasis, and so on, or I'll look up in the journal and or the chart and see what's what. They've been giving they're giving this treatment. What do we think it is? And this is really important. Like, what do we think it is? Like this game of, I think in trauma, they sometimes in EM cases they call it trauma quiz. Like, what do we think it is? Okay, it could be this. Yes, that's true. This is where we go from. What do we think it is? It could be asthma. Okay, we need to draw up Ventolin. Like, what do we need to do in order to hit the ground running when they're coming, right? Or be up at speed once they're coming in. We don't want to stand on our feet and not do anything. We need to be able to catch the patient once. We should think of it as a relay race, right? The ambulance is coming in, and we have to be up to speed before, like when they are coming. So we need to think about what measures do we take, and then we have some kind of plan the first few minutes. If it's a really sick patient, then it's only a 1 minute, 2 minutes, and then the plan changes. But it's good to know like kind of role assessment and kind of know what to do. And this is an entire lecture in and of itself on non-technical skills in the emergency room, and I'm not going to do that now. But this is just like what to do. And here's a small like one other model instead of the SBAR, or at least as a extra thing to the SBAR, is the STE, the self, team, and equipment. So am I ready right now? Okay, have I peed? Have I patients outside of the emergency or the resus bay where I need to like deload my cognitive problems, right? Or cognitive loading. So I have to give patients to other people or make other people take care of my patients, or so on. Have I eaten? Have I slept? So on. And oftentimes, sometimes you can do something about it. You can go pee, you can go give your patient to someone else, but not always. The team, is the team assembled good enough for what we need? Or do they have are they comfortable? Like, if it was a trauma and it's really like, then you have to know, like, the A person. Are you doing what the A person should be doing? Are you do you know how to intubate? Do you know how to intubate a pregnant patient? If that's the case, do you know, like, can you please, and then you can, like, if it's really likely that it's going to be intubation, then could you please prepare for intubation, or could you please have the trach kit here if it's difficult intubation and so on. So you kind of plan with your team both the equipment and what kind of team you need. And if you don't have everything you need, or someone is uncomfortable with the role that they have, then they should upgrade, right? See if you can get someone else in. The equipment could also be like, oh, someone is seizing, and we have a patient who's seizing coming in the ambulance, and they've already gotten 2 doses of diazepam. Then I know where we are in the algorithm. We're already far, like we don't draw up any diazepam anymore. We draw up 4 grams of Keppra, depending on their weight, and or 16 milligrams per kilo. And we call anesthesia because the third step is intubation here, and I want anesthesia to be down here right now to evaluate that even before coming, right? So that's kind of the thinking about this, and we need to get up to speed. Yeah, and then we reevaluate as time goes by in the case. What we call a 10 in 10. So every 10 minutes you take 10 seconds, just summarizing, now we were here, now we're here, and our plan is doing this. At this point, we may also do what we call, and this probably is the last concept I should introduce here, we may also do what you call a parallel process, or decide whether we want to do a parallel process ABCDE, or we want to do a serial ABCDE. So a parallel process ABC is something that we do if the patient is in a really bad way and we need to do a lot of things at once. Like, I don't have to, like, you have a doctor at the A, you have a doctor at the B, you have a doctor at the C, maybe DE, and then you as a team leader needs to coordinate this team, and they work independently, all of these doctors, but they go back to you as the leader when they have something important, and if they need to do something team critical like intubation, then they fall back and give you that information, and then you inform the team because each team member are focused on their task. And then when you feel like you need to, then you tell the team, okay, team, you do a 10 in 10. We have a patient with this and this condition. We have a trauma patient who's pregnant. We think she is. We think she has a tamponade, and she's in. Or she may be in cardiac arrest. Then you just shout cardiac arrest. Everyone reverts. We do not do compressions because it's a trauma. There's different ways of doing this, right? But the main thing is that with the parallel process, it takes a lot of non-technical skills. It takes communication, it takes team leadership, it takes team followership. It's really on the, and usually used in trauma, but can be used also in cardiac arrest, or it is used in cardiac arrest. It can be used in all kinds of situations where the patient needs a lot of resources at once. All right, and you can revert to that when you're the team leader in an acute situation. You can like cognitive deload yourself and say, okay, A person or anesthesiologist, could you take care of the A and intubate if you need to, and just tell me before. And you have some junior doctor, could you take the B and the C? Could you do the POCUS? Then you're kind of cognitively deloading yourself. And that's what we do sometimes as emergency physicians if we are triaging and we need to go into a emergency room, like or a patient at the bedside of someone who's really sick. Then we kind of make other people do the stuff because we need to go to the next room and the next room after that, because there's usually several things going on, several critically ill patients at the same time. So I don't want to be too attached at the same time, right? And then I give over the leadership when I need to someone else, and so on. Yeah, these are like, I have talked about this in other lectures, but let's go through this case, this specific case. So here, okay, I would usually say to my team, okay, we need if this truly is an asthma and it develops so quickly, we have to think about anaphylaxis, because that usually develops quite quickly. Even if it's only respiratory symptoms, quickly, and respiratory symptoms is still, I think, within the ballpark of anaphylaxis. I think it's, we'd have to look that up, but that's what you would do in this situation, right? Could it be pulmonary embolism? Could it be, so like these like things that we need to think about and not be prone to premature closure or framing bias, because he has asthma, he's a frequent flyer, he's alcohol abuse. So what we usually would do is just go through and my plan would just be, draw up Ventolin, get someone who can actually use the NIV apparatus or equipment, and we have that standby. We don't need to do it right now. Right now we don't need the anesthesiologist. Let's see how the patient looks like. Well, the patient looks like this. He is in severe distress. He's sitting upright. He can barely talk, and but he's awake. Has no stridor. Has no trauma. There's highly expiratory wheezing. No swollen tongue. No foreign body. He has an SpO2 on 10 liters with 98. And has a respiratory frequency of 30. A bilateral chest expiratory wheezing when we listen to him, and excursions, like he has big workup breathing. He's sitting upright and all right. High blood pressure, high heart rate. And of course, the heart rate can partly be because of Ventolin. That's in the back of my head, but there's lots of other things saying that he's in a bad way here. Just looking at this. But you might say, he's only 98 here, and it might be, but we need more data. But just the clinical, like the LLS score is 1 for this patient, not by what you see here, but what I'm talking to you about, and what I'm saying, like he's tripoding, he's sitting upright, he's barely speaking, he's concentrating on breathing. That's an LLS 1 if it's a COPD or an asthmatic patient, right? So we do our ECG. It cannot be done because the patient cannot do it under his condition. We do a really fast ultrasound. He has dry lungs. Okay, so what piece of information is really important right now? Do you have enough, like, should we treat generically, or should we can still treat generically or semi-generically? Like, he's wheezing, then that means that's Combivent or some kind of ipratropium and salbutamol is important to give, right? But not all that wheezes is asthma or COPD, right? But we need the arterial gas or venous gas for or like here, because what I need is the CO2, right, and the pH. And the problem is this patient's age is. It's like kind of, is it COPD or is it asthma? That's my main syndromes that I'm thinking of right now. And once we get this gas here, you can see that, okay, so it's a pH of 7.1. So he's acidemic. He has a low bicarbonate. So there's definitely a metabolic component to it, but it also has a respiratory component to it. And it's kind of hard to know which one is which here, but just by looking at the gas. But from looking at the patient who was severely breathing, it doesn't like it seems like this would be a respiratory acidosis. And if this is a COPD patient, well, then it's bad, but it's not that bad. A bit of NIV, and that's all right. If it's an asthma patient, then it's a peri-arrest patient, right? So, and it's there's no test to tell us that this patient is really in the gray area between COPD and asthma because of his age and because of lack of data. We may not have had a spirometry, and we may not have had any data from any other previous attacks. What tells us that this may be more asthma anaphylactic than COPD is the fact that it developed really quickly. We never know whether that bit of information is really like whether that is true. But we always we have to work with what we got. So asthma is the more dangerous thing, but actually it doesn't really matter that much. We can treat both right now because both need inhalation. So we give them continuous inhalations. Both need prednisone. We can give that. Again, we're talking about opportunity cost here. Do we really want to give that right now? No. What I want to give right now is I think that the patient is I think the patient is at risk of not getting the things into their lungs that we give them the medication, right? So I want them to give IV what they need, right? I want them to give either IV terbutaline, or if I don't have that, then I give then I'll give adrenaline, and adrenaline can be what you call dubbelspät or double diluted. I'll do that and give double diluted, meaning 0.001. So let's see, 0.01 milligrams per milliliter of that, and give maybe 2 or 3 a minute, or maybe up to 5 depending on the weight. But 1 microgram per kilo, I can give up to that per minute, or per 5 minutes, depends, right? Let's say per 5 minutes, that's the AMAX algorithm. But if I don't have terbutaline, and do I need to find terbutaline? How much time would that take? I have adrenaline right here. Would I get into trouble for getting IV adrenaline? Yes, I would, maybe. If I didn't call the anesthesiologist beforehand, depending on the anesthesiologist and so on. I would definitely at this point call, if I haven't already, call the anesthesiologist when I see this gas, because if this is an asthma patient, then I need their help right now. Or at least I need their support. These are the things like that. This is what we kind of want to do when we're thinking of the syndromes, right? Thinking in a more syndromatic way. Then going back to this, let's just pause and say, okay, there's also a metabolic component here. I have this mnemonic called, some have, let's say if you have a metabolic component, then you'll calculate the anion gap. 141 minus 106, that's 35, minus 20, let's say 20, that's 35, and minus 20, that's 15, and a guy this age would usually have an anion gap around, we usually say it goes from 8 to 12, where 12 is for elderly patient and 8 is for children. So maybe a 10. So there might be a 5 anions missing, right? A delta, what you call delta gap of 5, because 15, which was the anion gap, minus the 10, which is the basic, or this patient's basic gap. Maybe it's between 2 and 5, right? It's not an exact science, but just a small high anion gap metabolic acidosis. There's a bit of lactate, might be that, but the differentials is KULT. K for ketones is an alcoholic. I would take ketones here because there might be like an alcoholic ketoacidosis or something like that. Uremia, well, we have this luxury gas where there's creatinine. It's not uremia, probably not, at least unless they're coming from 42 or something very low. Lactate might be a bit of a component, but not that much. And toxic, well, it could be toxic reason. They could be drinking toxic alcohols. Usually they have a very high anion gap, but it could be early on and so on. So this is my thinking here, but this is the syndrome that I really want to manage right now. So I don't really care about this too much right now. And as I said, nebulizing is not working. The patient is getting worse. What do we do? And as we said, we call anesthesia. We've already done that. We give continuous complement or a combination of salbutamol and ipratropium. We give IV, subcutaneous or IV adrenaline or terbutaline, depending on what we have. And then we can do the kitchen sink thing. We can give magnesium. Give magnesium. We can give sometimes in some algorithms we can give thiophylamine as well. we will give corticosteroids. But we know that this will only work in a while. This is not something that like we need anesthesia now. We don't want to intubate this patient, and we want to have a plan. If they suddenly becomes unconscious, what do we want to do? If this patient, and we'll talk about that right away, if this patient becomes unconscious, we want to intubate them. We only have 4 minutes to do that. So as an emergency physician, even though I said in the beginning of this lecture, I don't want to intubate anyone. I don't think the patient is well served by me intubating anyone. But if I'm in a situation in one of these what we call halo scenarios, high acuity, low opportunity, really rare scenario where you have an asthma or anaphylactic patient who suddenly collapses, then it's not from hypovolemia, it's from hypoxia. And the hypoxia, like then if they collapse, then they don't breathe, and they have abnormal breathing, and they have abnormal breathing, and they have they are unconscious. That's a cardiac arrest, right? So do we want to press on the chest? No, we want to intubate them. And that's me doing that because I only have 4 minutes to get that tube in. And if I don't get the tube in, or I'm not allowed to intubate, then I'll just do a trach, right? The reason why I can say I will do that, because I've visualized how I'll do. I've trained this in my mind and through colleagues and so on, and that's why that's my plan. That's my mind map. That's my cue. If I have one of these patients, then I will do that. Of course, depending on the context and situation, but that's my trigger. Asthma anaphylactic patient who's unconscious, then that's me intubating if I don't have anesthesia, who can come down within 1 minute, because I only have 4 minutes until brain death or brain ischemia. Okay. So, but we're not quite there yet. That's just what we will do if that happens. Maybe NIV, that could happen. It's not really in the guidelines of asthma patients, but I've definitely treated asthma patients with this, who in which it worked. And there is this YouTube channel or YouTube link for Rebel EM who has also done it. And then there's this thing called rule of two. That's one of the mind maps from before, where you have either it's a ventilation problem, right? You have a respiratory distress. Either it's a ventilation problem or it's an oxygenation problem. If you have a oxygenation problem, like on the gas, you see that they have a null or low, usually hyperventilating, low PCO2, but they have a hypoxia, primary hypoxia, right? And then what they need is CPAP and FiO2, right? That's what they need on the NIV. And if you have a ventilation problem, then what you need there, like if you have a hypercapnic patient, then usually you'll need an IPAP. If you have a respiration problem where they have hypoventilation, NIV cannot help you with that. So because then you need intubation. You cannot like some NIV machines can ventilate, but it's a bit risky. So that's not what you will do. You will intubate the patient who's or try to reverse the reason why. It could be if you need to give them naloxone. That's a quick save, but otherwise you'll temporize until you can intubate them. Ventilation is all about the IPAP, or what you call the delta. So the delta. So it's like the difference between IPAP and EPAP, or in Swedish tryckunderstöd. So, for instance, if you have a patient who has, usually we start with 10 in IPAP and 5 in EPAP. Then you have, if you have a patient who has a primary hypocapnic problem, like a ventilation problem, then you will increase your IPAP so that the delta, so let's say you 10 and 5, and you'll go up to 12. That means that your delta is now 12 minus 5, which is 7. And so on, like so you can keep increasing your delta. And usually that's what you do in the COPD patients. And when you know it's enough, well, you know it's enough when they are responding in the CO2, and you can see on the titles. If the tidal volume is like a rough estimate is 6 milliliters per kilo of body volume, or ideal body weight, sorry, then you kind of know it's around the ballpark of maybe 400 to 700 usually, depending on the body size of the patient. So you need good titles to ventilate that out. So that's kind of the rule of twos of NIV. You have two kind of conditions that you have to treat. One is CPAP, that's usually pulmonary pulmonary edema, which can be reversed. There's also all the other hypoxic conditions, but they cannot usually be reversed. That's only temporizing. And then you have the other reason of respiratory distress, which is hypercapnic. And then here you will have to do the delta, the difference between IPAP and EPAP. And we'll go into details about this right away. So when you look at the screen of the NIV machine here, you will see IPAP, EPAP, and FiO2, the inspired amount. And it goes from 21, which is room air, up until 100. And you can check up for leak. You want them to leak as like it should not be 0 because then it's a vacuum kind of seal, but it should not be above maybe 20. So you kind of adjust the mask until you get the right amount. You can check the respiratory rate. It should be normal. You cannot adjust the respiratory rate at all. That's where you need to intubate them if they're doing everything fine. And you can check the tidal volumes. If the tidal volumes are too small, then they're hypoventilating. That's where they need tryk understøt. They need some kind of help when they're breathing in. Right, and that's what you can do with the delta between these two. Here's exactly. And how much can the delta be? Well, or the max IPAP is 25, right? You cannot, because that's the esophageal sphincter pressure. So you're not allowed to go above 25. Theoretically, I guess there are cases where you can, but then there's a higher risk of aspiration. Can you put a mask on someone who's unconscious? Yes, you can if you're not intubating them and you don't have any other choice, as long as you're bedside at them and you can help them if they're vomiting, right? They shouldn't be totally unconscious, but a lot of the CO2 hypercapnic patients with COPD really need NIV, and they're not being intubated, but so they need NIV. And you just need to have the monitoring, like a nurse or a doctor at them all the time, so that if they vomit or if they have a problem, they can pull off the mask. Yeah, the leak should be below 20 to 25. Here you cannot touch this. And here it is 6 to 8 milliliters per kilo of the ideal body weight. Yeah, and if the ventilation is not adequate, then you go up on the IPAP so that the delta increases. The primary goal, well, of NIV, that is workup breathing improved. Secondary is the gas exchanges. The gas exchanges takes a while. So what I want to see on the patients is that the gas exchanges become better over time. But again, this is a clinical gestalt. Like don't think of the monitor. Think about how the patient is looking. And if you have a patient who gets NIV, and you ask them, are you doing fine or are you doing better? And usually they can say it's better, or they might say that it's really they're doing it's much more comfortable. You can see that it's much more comfortable because they relax and their workup breathing decreases. Okay, so if they're failing NIV, what does that mean? Well, that means that they're not calmer. Their workup breathing is not calmer, or they're hypoventilating again. That we have to intubate them. They cannot do anything. If you want to know more about like intubation, then look up my airway lectures. But in short, you have something called the hop killers, hypoxia, hypotension, oxygen, and pH. If you have low pH, low oxygen, low blood pressure, then it's highly likely that you're going to arrest during your intubation attempt because of the entire procedure and the sedation that you need to give, or induction agents. So you need to and because of your ventilation, the positive pressures that you're giving. So you kind of need to resuscitate before you do that. But sometimes you have your back against the wall and you can't do anything else. All right, but NIV, if they're not calmer, then you need to then they might be failing NIV. If they are not improving, and that's usually over hours, more than seconds to minutes, and you need to calculate the baseline of their PCO2, because a lot of CO2 patients, like COPD patients, have a baseline CO2 that is quite high, and we just look at a quick way is looking at the pH and seeing whether it's normal. If the pH is normal, then usually it's kind of they're at baseline or they've compensated. Here's a way of calculating the baseline. For every 4 bicarb on the gas above 24, PCO2 goes up 1.33 in chronics. Then you can calculate. Yeah, exactly. Do they need intubation? And the indications for intubation are like you can look at this like graph from the airway, the Canadian, what's it called? AIME airway, AIME airway, Infinity version is an internet book by George Kovacs and others. And they've done this. How urgent is the intubation? Well, if it is to obtain and maintain an airway, if the airway is closing in front of you, then it's really urgent. Then you have to do it now. If it is to correct CO2 or O2 problems, then that's also quite urgent, but not as urgent. Protect the airway from aspiration. Well, that's like if you have a low GCS, that's also important, but not urgent. And or if you have a like what you call a dynamic airway, or you have a burn victim with who have blisters in their oropharynx, that's someone who wants to intubate, but not within not right now, but within maybe 5 or 10 minutes. Or maybe 20 minutes. You can resuscitate them a little bit and assess them and do other things to make them less risky. And then there's the thing like is increasing likelihood of failure of intubation. Well, is failure likely? And that's an entire lecture on its own about the psychological and the anatomical problems and so on, but of intubation and the hop killers, as I talked about. But in general, if you have a high if you have if you're up here, the airway is not patent or it's closing really fast, and failure is really unlikely, it's really favorable conditions, then do it. But if you have someone who has a deteriorating airway, like a burn victim, but they're also really hypotensive and they have a pH that is really bad with a high lactate from cyanide poisoning, it's probably better to wait. Failure is really likely that they will go into cardiac arrest. So wait 10 or 15 minutes until you can actually resuscitate them. Where our patient falls on this spectrum, if he arrests, then failure is quite high likely, but then also the main, like we are up here, so we want to do that. That's just I like this way of looking up indications of intubations. And as emergency physicians, we kind of think about these things as well. Even though we don't do the intubations, we are the team leader and we need to weigh in the risks and benefits of doing a procedure, including intubation. Okay, so they're failing NIV, they're not calmer. Do they need intubation? Maybe not. Is it mask problems? Like, are they not accepting the mask and put it on themselves and like make a more calm environment? Start with low CPAP and IPAP. And maybe sedation as well, Dextor, let themselves hold the mask first, and different things can help here. Air leak, use a different mask. There are these masks that are fitting the entire head. They can work. And then either if it's an oxygenation failure, we can increase the EPAP and make sure if there's also a problem with the CO2, then also if you add EPAP, then you're decreasing the delta. Like if you're going from 5 to 7 and the EPAP is 10, then you're decreasing the delta from 5 to 3. So if you want to maintain the same delta, then you have to say go from 5 to 7 in EPAP, and then you have to go from 10 to 12 in IPAP, maintaining a delta of 5, and then you're increasing the EPAP, right? Just make sure that the higher number, the IPAP, is not above 20 to 25, because that's the esophageal sphincter. Exactly. And then you can also increase the FiO2. So sometimes when you have a patient in intermediate departments or on NIV who's been there for a while, then usually you can say they're maxed out on their NIV and they're maxed out on the FiO2, and that's a problem. Then they're kind of either pre-intubation or failing NIV. And the ventilation is kind of like, are they hyperventilating? That you cannot do anything about that. Are the titles adequate? If not, increase the delta. or increase EPAP or in COPD patients sometimes because they have atelectasis. So sometimes it can, even in COPD patients, it can be good to just give a little bit of EPAP because COPD patients are also doing like with their they're auto peeping with their lips themselves. So it can help sometimes. Okay. Shit, the patient is unconscious now. Oh my god, what are we going to do? Do you remember? So there's this algorithm came out and has been going around the internet, at least the emergency medicine internet, foam as it's called, for the last couple of months, and it's a really great lecture. The AMAX lecture is really emotional, and I highly recommend looking at it. But it's hard to watch because it's this emergency physician, Australian emergency physician, who had his child Max be the victim of, or he had asthma and had an anaphylactic reaction with only respiratory symptoms, as I recall it. And when he came in, he was kind of in a bad way, and he almost got unconscious in the ambulance, I think, on the way in. And they didn't have the cue to intubate him right away because they could back him. And when you can back someone, but there are high pressures in their lungs, then usually it goes to the stomach. So that was what happened. And this, long story short, the emergency physician who's made this algorithm and who's made the lectures, he had to both do try the intubation and do a emergency tracheotomy on his own son, and sadly he didn't survive. But it's really a great lecture, and there's a high clinical value of looking at it, because checking out this algorithm and getting these cues and updating your mental maps in these situations, so that we can save these patients, or at least make them better in this really critical situations, are important. So what's the most important here? I will just get you to go see the lecture. I've made a video on this as well. But in short, time is really important. With this patient where we have asthma, and who they crash really fast because of small caliber changes, like a tube that changes just 1 millimeter has I think it's Purser's law or something like that, but it's really like the airflow gets really much lower really fast. Majority of them die from B problems, not C problems, if it's asthma anaphylaxis. And so there's no reason to pump the chest if you think it's a cardiac arrest when they become unconscious, or it should be low priority. You should intubate them. You need to get oxygen in their blood, otherwise it won't help pumping the chest. And you have 4 minutes. That's why it's called AMAX 4. So what you do is give adrenaline. You get, if the IM route is not that good, or it takes 5 to 8 minutes on onset, and you only have 4 minutes. And in the worst case, you don't give it IM, you give it subcutaneous. You miss the muscle, and then you give it. Then it takes 20 minutes until onset. IV takes seconds. So do the dubbelspaltning, or 0.01 or 0.01 milligrams per kilo, and then give it in these doses here. And I'll show in the next slide how you could give it. That's the important thing. And then the next thing, maybe not for internal medicine, but we could do this as emergency physicians. Take the video laryngoscope and do a dry or give muscle relaxants. And then we just intubate. If anesthesiologist is not 30 seconds away, like you have 4 minutes. All right, and then once you get intubated, then you squeeze the chest to let all the compressed air out. Yeah, there's lots of other stuff, and then just to show this is the vortex method, I will say that go to the lecture on vortex on the vortexapproach.org, I think, or .com. It's an Australian approach that we use. And in short, it's just for airway maneuvers. You have 3 advanced airways, and you can only attempt it once in a perfect way. Or you can optimize the situation and try it 3 times. But you need to optimize it every time. And sometimes you have back valve masking, you have laryngeal mask, LMA, and you have intubation, and you have your cricothyroidectomy or FONA, front of neck access. And as you fail one of these, you'll slide down and then come into the FONA. And in this, sometimes you have what you call surgical inevitable airway, where there's no if you have someone with a trauma in their head or they have a swollen tongue, you might as not. You can try, but you should only try once, or you shouldn't try anyway. This is a surgical airway, no matter what. You need to do it and a tracheotomy right away, because there's no use of trying these conditions if the entire mouth is full of blood, or maybe not blood, but tumor, or a tongue that is swollen. Then it's better to just do what needs to be done. Yeah. How do you mix the adrenaline? Well, I have an entire lecture on this, and I will jump through this at this time because of time constraints. Yeah, so for our take home for this second part of the lecture, for the specific case, I am adrenaline is important, and don't use your time on things that are not important, like corticosteroids, or in a patient that is really bad, because that will only work in a matter of hours. What you call opportunity cost, and you need to know how to draw up adrenaline. Please look at my other lectures on that. Yeah, and that's it. These are the two lectures that I've done on chest pain and dyspnea, but mainly they're about how to think like an emergency physician for internal medicine. So I hope you, if you watched through these 2 hours times 2, then thank you. And you can always come and ask me to do lectures both with a case base, or do cases with you, or we can explore other areas of this which I just talked about, or which I have several themes on my YouTube channel and on my blogs where we can check out other topics within this if you're interested. Thank you so much, and bye.